Hello and welcome to the Surgeon's Burrow. In this video, we'll be discussing the fluid resuscitation in burns. Now, this is a very important topic and it is often asked in exams. And it is very frustrating to remember. I, as a student, had considerable difficulty in remembering these formulae. So, I hope by the end of this video, I make it slightly easier for you to be able to remember these formulae. Now, the fundamental difference between resuscitation in burns in a thermal injury and other injuries, for example trauma, is this. So now in a normal, in a non-thermal injury, supposing there's an RTA, this patient comes to your casualty and you locate the source of his bleed. So you ligate the vessel either in the casualty or in the OT, you control the source of bleed and then you resuscitate. So basically in this patient you are giving fluid which is replacing that which has already been lost. So this is why there's so much importance in how much blood could have been lost. So that is why you have, even in OT as well, you have these ways of remembering. What is the amount of blood contained in a gauze piece, in a fully soaked gauze piece, or what is the amount of blood in a human fist. So in these patients, you are replacing that which has already been lost. Now this differs from a burns patient because in a burns patient, due to an inflammatory response, there is ongoing fluid loss. This means that there is no source of bleeding that you have to control. All right. For example, with a tamponade or with a ligation. In this, it is ongoing, and this ongoing is because of the inflammatory response. This is why fluid resuscitation becomes so vital and so important in a burns patient. So now, when do you give fluids? You will give fluids. Okay, first you have to calculate the total percentage of the total body surface area which has been burnt. Now, that is in a separate video as to what is the percentage of body surface area that has been burnt. So now you've calculated the percentage of surface area which has been burnt. In children, the magic number is 10%. So supposing if it is more than 10%, you will start the child on fluids. In adults, you will start the patient on fluids if it is more than 15%. In this video, we'll be taking a look only at the intravenous fluids. Okay, before I start, when do you start giving fluids? Now, say this is 0 hour. Alright, and this is when the patient has suffered a burn. Now the patient comes to a casualty, let's assume that he stays slightly far and he takes 4 hours to come. Alright, so when he comes to, so in all these formulae and burns, there is a lot of emphasis on time, the first 8 hours or the first 12 hours or the first 24 hours. Now the time is always calculated from the time of burn because that is when the pathology starts. It does not start from when the patient comes to the hospital. The patient may arrive late, the patient may arrive early. So the time when he comes to the hospital is not important. We are more bothered about at what time the burn happened because that is when the pathology starts. Okay. Now the fluid loss is maximum in the first 8 hours. Again, the magic number here is 8. So supposing say the patient has suffered a burn at 12 p.m. till 8 p.m. This is the maximum amount of, this is the time period for when he will have maximum fluid loss. This is why you have to give higher amount of fluids in the first 8 hours and then you have to taper it down after that. So it's maximum in the first 8 hours, you taper it down after that. And supposing if all is well, if the patient's vitals are being maintained, if he has not suffered any other injury, if he has not suffered very high percentage of burns, then by 24 to 36 hours, you can start maintaining the patient on their normal daily requirements. Okay, so now what fluids do you give? So first you can give crystalloids. These crystalloids are either Ringer's lactate or Hartmann solution, which is nothing but Ringer's lactate, or you can give colloids. Colloids are rich in proteins. You can give either human albumin solution or you can give fresh frozen plasma, and you also have an option of giving hypertonic saline. So these fluids are used. Now the most commonly used fluid is Ringer's lactate or RL. Now Ringer's lactate is a crystalloid. So now there is a debate as to which is better. Should you give crystalloid or should you give colloid? So they realized that it is not very different from giving colloids. So the extent to which it is beneficial is the same for crystalloids as well as colloids. One advantage of crystalloids is that it is less expensive. It is less expensive. It hardly costs anything when compared to human albumin solution or fresh frozen plasma. Now, another thing that you have to keep in mind is, so now these are arteries, these are arterioles. I'm sorry, I'll draw a fresh diagram. This is an artery. These are the capillaries, and these are the venules and the veins. Now what happens in burns is these capillaries become very leaky. They become very leaky. So even if you were to give colloids, the albumin particles, the albumin molecules would leak out. So it would serve no purpose. That is why crystalloids is preferred over colloids. Now there is the most commonly used formula for giving Ringer's lactate is your Parkland formula. Now for all formulae, as you will see, there are two things which are always constant. One is the percentage of burns. The second is the weight in kgs. So this is relatively constant in all formulae. What changes is the number by which it is multiplied. So let us say the patient has suffered 50% of burns. And let us say his weight is 100 kgs into 4. So this makes it 20,000 ml has to be given. Now this 20,000 ml is divided into two halves. This 20,000 ml is over 24 hours. Let me mention this over here. Volume in ml over the first 24 hours. Now this 24 hours is divided into two time periods. The first 8 hours and then 16 hours. This 20,000 ml is divided into two halves. So 10,000 ml is given in the first 8 hours, and then the remaining 10,000 ml is given over the first 16 hours, is given over the next 16 hours. So as you can see, a higher amount of fluid is given in the first 8 hours. This is because, as I already told you earlier, the maximum fluid loss in burns because of the inflammatory response is in the first 8 hours. So you give 50% in the first 8 hours and the remaining 50% in the next 16 hours. Okay. Now in children, by children I mean whose body weight is less than 30 kgs. So in children who are less than 30 kgs, along with your 20,000 ml that you have given over here, not 20,000 ml, I'm sorry, along with the fluid that you are giving in by calculating the Parkland formula, you also have to give maintenance fluid. So let us say we have a child who is, let me erase all this. So let us say we have a child who is 30 kgs. He suffered 50% burns, 30 kgs into 4. So this would mean 5 4s are 20. (6,000 ml). So this 6,000 ml you will give in the first 24 hours. Now along with this 6,000 ml, you also have to give the child maintenance fluid, because in children you have to give more fluid. Now this maintenance fluid, it should contain sugar, it should contain dextrose. So it can either be DNS, that is dextrose in normal saline, or it can be a combination of 5% dextrose plus Ringer's lactate. The common factor here being dextrose. Dextrose is present in this combination as well as in this combination. So along with the 6,000 ml, you will be giving some maintenance fluid which contains dextrose. This maintenance fluid is again decided on the body weight. So you will give 100 ml per kg for 24 hours for the first 10 kgs. This means, so our child is 30 kgs. So first 10 kgs, next 10 kgs and over 20 kgs. So first 10 kgs, let me use a different color for simplicity. First 10 kgs you will be giving 100 into 10, that is 1000 ml. Then you will give 50 ml per kg for the next 10 kgs. So the next 10 kgs you will give 50 into 10, that is 500 ml. Alright, and then you will have to give 20 ml per kg for each kg over 20 kgs. So in our case, our child is 30 kgs. So 30 minus 20 is 10 kgs because he is 10 kgs over 20 kgs. So the last 10 kgs you will give 20 ml into 10. Supposing if you were 28, then this number would have become 8. But because our child is 30 kgs, it is 20 into 10. So 20 into 10 is 200 ml. So this comes up to 1700 ml. So our child will receive this 6000 ml plus 1700 ml. This plus is very important, and this plus is given to children who are less than 30 kgs of weight. Okay. Now, as we discussed earlier, you can give, first you will give crystalloids, colloids, you can also give hypertonic saline. Now, we have discussed crystalloids, let us look at hypertonic saline. Now, hypertonic saline, so normally your the NS which you give in your wards routinely is normal saline. So, it neither allows water to enter from these tissues into the vascular space, nor does it allow the water to leave from the intravascular space to the tissues. But with hypertonic saline, that means it is more than normal. So this is one normal saline. For example, we use, so anything which is more than one. So you will get hypertonic saline. Now the advantage of this hypertonic saline is it produces hyperosmolarity and hypernatremia. What happens because of this hyperosmolarity and hypernatremia is because of the physics of osmosis, it reduces the shift of intercellular water to extracellular space. So there is less tissue edema. Now one problem with burn patients is that there is quite a bit of tissue edema. So a consequence of the tissue edema is, supposing say the patient develops tissue edema in his limbs, in his upper limb. So what happens is, there is the circulation gets impeded to the distal tissues, and then the patient will require an hysterotomy because of to improve circulation. Another problem with tissue edema is that so normally the IV lines that we use, they get displaced because of the edema. So in burns patients you have to use longer lines. Now longer IV lines may not be available. So when you are giving a shorter IV, when you are inserting a shorter IV lines, and say because of edema the line comes out, it is very frustrating. So if you have less tissue edema, it is advantageous. And hypertonic saline, it results in less edema. Lastly, let us look at colloid resuscitation. Now, colloid resuscitation is given, it is always given after 12 hours. Let me use a different color. It is used after 12 hours. Now, why is it used after 12 hours? This is because, as we discussed earlier, so I'll tell you where I discussed this exactly. So what I told you here was, these are the arterioles, these are the capillaries, and these are the venules. So initially the capillaries are very, very leaky. So even if you give colloids initially, it is of no point, because the colloids will leak out. That is why you give colloids after 12 hours. 12 hours here is the magic number. After 12 hours, you will give the patient colloids. Now, for crystalloids, the formula that we used to calculate was the Parkland formula. With colloid resuscitation, we use a formula called the Muir and Barclay formula. So whenever you are writing answers, or whenever you are looking at patients in your burns wards, you have to bear these two formulae in mind. First was your Parkland formula, second is your Muir and Barclay formula. Now this Muir and Barclay formula is very, very interesting. It looks complicated at first glance, but it is actually very, very simple. So let us take a look at it. So this is our 0R when the patient has got burnt. Now on the first 12 hours, you will not be giving any colloids. So this gets cancelled. So you will start giving colloids only after 12 hours. Alright. And you will give colloids over the next 36 hours. This is the time frame in which you will be giving colloids. Now this 36 hours is again subdivided into 12 hours, 12 hours and 12 hours. So you have three time periods, three equal time periods of 12 hours, 12 hours and 12 hours. Alright. The first 12 hours, that is this, is further subdivided into three periods, 4, 4, 4. The next time period of 12 hours is subdivided into two subdivisions, 6 and 6. The last one of this last 12 hours is just one time period of 12 hours. So there is no subdivision in this. So you have three time periods over here. Here you have two time periods. And here you have one time period. Now one portion of colloid, one portion of colloid is given in each period. So this means there are three time periods, so he will receive three portions. Here there are two time periods, so there will be two portions. Here there is only one time period, so there is only one portion. Now, what is the amount that is present in one portion? So the formula for that, this is the Muir and Barclay formula. One portion is equal to 0.5 into percentage into weight. Now, if you remember from our Parkland formula, let me scroll up and show you the Parkland formula. Here you have percentage of burns. Here you have the percentage of burns, and here you have weight in kgs multiplied by 4. So like I said earlier, the percentage of burns and weight in kgs is always constant. So here the percentage of burns and weight is constant. This factor by which it is multiplied is changed. There it was 4, here it is 0.5. So 0.5 into percentage into weight, this is in ml. So let us say our patient has developed 50% burns, he weighs 100 kgs. So this would be 0.5 into 50 into 100, that is 0.5 into 5000, which is 2500 ml. So 2500 ml is in one portion. So here he will receive three portions. So he will receive 2500 into 3 equals 7500. Two portions, so 2500 into 2 is 5000 and into 1 is 2500 ml. Okay, so this is the discussion of Muir and Barclay formula. Now whatever we've discussed so far is from the 27th edition of Bailey and Love. There have been certain updates in the 10th edition of ATLS. The American Burn Association realized that with Parkland formula it is causing fluid overload. So they came up with certain changes to the Parkland formula. This is not mentioned in the current edition of Bailey and Love, that is in the 27th edition. In the 28th edition, they may incorporate these changes. So here what we see is, in adults and older children, that is children who are more than 14 years old, you will use, again the fluid used is Ringer's lactate. So here what is LR is nothing but Ringer's lactate. These Americans want to be different, so they call ringers lactate as lactated ringers, but RL is the same as LR. So in age more than 14 years old, forget this adults and older children. In age more than 14 years old, the formula is 2 into weight in kgs into percentage of burns. So here again, this weight in kg and percentage area of burns is the same, is constant. This factor has changed. So in more than 14 years, the factor is 2. In children less than 14 years, because children require more fluids, it is 3 ml. Sorry, it is 3 ml, 3 into this constant formula. And like we said earlier, like we discussed earlier, for weight less than 30 kgs, they require a maintenance fluid. So along with this, what children are receiving, that is your 3 ml into kg into percentage of burns, that is this. He will also get a sugar containing solution at maintenance rate. This maintenance rate is the 100 ml per kg for 24 hours for the first 10 kg, 50 ml per kg for the next 10 kgs, and 20 ml per kg for each kg over 20 kgs. Okay, so just to recap, for more than 14 years old, it is 2 into kg into percentage of burns. In less than 14 years, the number is 3. But if it is less than 14 plus and the child weighs less than 30 kgs, you will give a maintenance solution. So this is about the fluid resuscitation. Now, whenever you are giving fluids, it is always important. You have to bear in mind that you are not giving less fluids, but it is also vitally important that you are not giving more fluids. You are not over resuscitating the patient. Now, the resuscitation will be discussed in a later video, but what you have to bear in mind is that the resuscitation is monitored by taking a look at the urine output. So you insert a Foley's catheter and you measure the urine output. So in adults and older children, the urine output should be 30 to 50 ml per hour, which is roughly 0.5 ml per kg per hour. In less than 14 years old, it is 1 ml per kg per hour. So supposing if the urine output is less than this or more than this, you can titrate the amount of fluids that you are giving. Okay, so I hope in this video I was able to make your concept slightly clearer and you're able to remember these formulae. I as a student was used to struggle to remember these formulae, your Parkland formula and the Muir and Barclay formula. Okay, thank you so much.